together, but as a working mom, I know you are busy, so I want to take full advantage of the time we have together. Many of you know me, but if you don't, I want to just introduce myself. My name is Rachel Schaefer. I'm a licensed acupuncturist and herbalist as my original training 21 years ago. But since then, and throughout my career, I've done quite a lot of study in the study of integrative medicine, functional medicine, and naturopathy. I'm right now in the final stage of a clinical doctorate in which I'm studying integrative medicine and women's health. So this is an exciting chapter from a standpoint of looking at this new phase of care for women's lives as we come into midlife and wanting to optimize that time. The first decade of my career, I was focused almost exclusively on the treatment of fertility. And this gave me a very intimate vantage point with the hormonal body of women. And it's been a really neat honor to be in practice as long as I have been, because now many of my patients for whom we escorted through the process of fertility are now coming through the stages of perimenopause and menopause. Also, I think it's a really pressing topic because, as we all know, we are being bombarded from social media and other platforms on the topic of perimenopause and menopause. I think it's excellent that these topics are becoming more transparent and more important in terms of women's health. I think women have moved through these chapters for a very long time without support. But I also really think it's important to talk with patients and the population as a whole about what some of the specific considerations may be during this time, about how we can optimize, how do we approach things like sleep, metabolism, what about the question of HRT, pros and cons. So I just wanted to attend to those things, and also at the end of my talk today, we'll leave some time for some Q&A, because I want to make sure specific questions you come in with that we're able to attend to too. So that's sort of the format. If as we go, anything feels like it wasn't clear, feel free to cue me. This is a conversation, as it were, but the first part will be more my speaking in a bit more of a lecture format. Please keep your questions too, and we'll make sure to attend to them, okay? Thanks for being here. So I just want to get started a little bit with even the definitions of what is perimenopause and what is menopause. Now, it's interesting because menopause, from a standpoint of conventional medicine, is fairly arbitrarily described. And what I mean by that is that many women will not even know when they're in the last stint before menopause, because essentially menopause is now defined as 12 months without a menstrual cycle. And then women are said to hit menopause. Many women may be on oral contraceptives or have other changes that will make it not evident to them that they've even moved through that transition. So the fact is that perimenopause is also something that I think is really important to set women up with an understanding of, because in candor, perimenopause for most women will be about a decade-long process. So I'll speak first about the two phases of perimenopause, how they differ and how we approach them and think about them clinically, and then what's relevant to that transition at menopause and beyond, and how we want to think about that both from a preparation vantage point when we're in perimenopause and from an attention standpoint when we hit that menopause transition. One thing that I think is worth noting is that in many ways, perimenopause is like reverse puberty. Okay? So this is an important thing to say, and I think in part because a lot of us know and likely have children that are in this transition now, where we're watching our kids moving through this pubescent phase and seeing how relatively erratic it can be for them, also from a standpoint of mood, changes, growth, sleep, and in some ways, our walk towards menopause is similar to their walk through puberty. And so we'll talk a little bit about specifically what's happening hormonally, but I really want to honor that fact that it's an extremely dynamic time. Just as we're observing for our kids, it's a very dynamic time for them too. So perimenopause has two stages. The first stage of perimenopause tends to be the longest, and what's relevant to that is that it's related to two features. So as most women hit their late 30s and certainly in their early 40s and beyond, most women's egg quality will begin to decline. This is normal. We're told this is in part why achieving pregnancies and healthy pregnancies at that stage is more challenging. And how this reflects on our hormonal body is that in many ways, what happens here is that progesterone, which is the secondary hormone, which many of us recall is really in charge of the luteal phase. So that's from ovulation until our period each month, ovulation being mid-cycle. When we have lower quality fitness in our eggs don't have as much progesterone to contribute to that second half of the cycle. And so one of the things that will happen is women will either stop ovulating completely because that fitness of the egg is what's required to come into that ovulatory phase, or women will also have eggs that just have less to contribute. The egg itself is actually the central force and ingredient for our endogenous production of progesterone. So when our egg's fitness is lower, our overall progesterone levels will be lower too. This is important because the luteal phase of progesterone has a very strong influence on our nervous system. Progesterone is the hormone that contributes to the production of the only inhibitory neurotransmitter, which is GABA. So when our body starts to make less progesterone, we start to have less production of GABA. With less GABA, which allows us to be more relaxed, at ease, improves our sleep, women will often find in this stage that they feel like they're more vigilant, activated more easily, have a harder time sleeping. There's more to do at this stage of our lives to begin with, so sometimes it can feel already like it's hard to tease out. But for me, there are some tells in clinic that would highlight to me that progesterone may be a very important target for a patient. I see that she describes luteal phase insomnia. Once my period comes, I sleep well. But before my period comes, that couple of weeks, I feel more anxious, more agitated, heightened levels of PMS. Some women will also have symptoms like fibroids or other establishment of symptoms that are really related in part to the fact that estrogen no longer has its opposition or its dance partner in progesterone. Estrogen left unopposed can become more inflammatory and anabolic. So women may have heavier bleeds as well, and they may have shorter cycles because in fact, progesterone is the glue to our menstrual lining. So without that glue, the lining will fall apart more easily. When women are bleeding in shorter cycles and with heavier bleeds, fatigue can also be a result of that because women will also sometimes become anemic. They're losing more blood more regularly. So these are all things in clinic that we do testing for, and we look at to evaluate for each woman how this first phase of perimenopause or progesterone deficiency may be looking like for her. In terms of treatment strategies, based on our evaluation, sometimes we give a woman progesterone, and we may give it just in the second half of her cycle. It's given at nighttime because it's very effective in improving her sleep and this activation state or hypervigilant state. But we also have excellent herbal strategies that can be effective in our own endogenous production of progesterone, things like Vitex or customized herbal formulas. I should share that because I've been in practice for so long, the first 12 years or so of my career, we did not use hormone replacement at all. It really hasn't been since I'd say the last 7 years or so, where the debunking and the data has really been suggestive to us that for many women, hormone replacement is safe. And then we take another step back in the personalized way we treat in clinic. And we want to evaluate for each woman what her particular recipe of HRT would be. Because for each woman, the ratio of those hormones as we replace them, it's relevant to her absolute levels of those hormones and also how she processes those hormones. So we look at metabolites in clinic, which is something that on the conventional side, they don't run. I will tell you, I feel empathic towards conventional providers, OB-GYNs, in part because, one, to be candid, they don't have a lot of training in this stage of women's lives. And they're excellent surgeons, they're excellent in terms of delivering our babies and so forth. Obviously, they have many skills I do not. The training in terms of hormone replacement and how to evaluate women on a personalized level for hormones is simply something they haven't received. And part of that is because they were trained and come of age at a time when the Women's Health Initiative, which came out in 2001, suggested that hormone replacement therapy was not safe for women. We have very much seen that data debunked, and I'll speak a little bit later in that conversation as to how it's been debunked and what we understand about that data now. But as a result, a lot of our providers didn't get that kind of training. So I think we're all going through a sea change this way, but I also feel that now that women are coming and asking of their conventional providers to provide HRT, there still remains quite a lot of misunderstanding. And I think all of us are learning anew. Stage 2 of perimenopause, this second phase, is when women's estrogen levels begin to decline. So we already have a loss of progesterone. That is a feature in our reduced estrogen because actually progesterone is involved in estrogen priming. But the other piece here is that as estrogen declines, which is really the final hormone that will decline before women stop menstruating at all, we'll see that women will start to have more the symptoms that we may associate with menopause. So this too can last a few years, this stage where estrogen is coming down and waning. Women will have more night sweating, hot flashes often. They'll feel more mood dysregulation. Estrogen has a very intimate relationship with serotonin production. So when women aren't making as much estrogen, they will sometimes present as their chief complaint to me in clinic, not as much with the heatedness, but more with feeling like they have an extended level of irritability, discomfort, more frustration. And some of this can be related to that lack of serotonin production. We also know that this is a very important stage to elucidate for our patients because one of the things that estrogen does for us is it maintains the structure of our bone mass. And so what we see, and many of you may have seen at our clinic Ginkgo, which many of you know, but it's right across the street here, we really want our patients to have regular DEXA scans. DEXA scans are a tool that allows to evaluate for a woman's bone mass, also her muscle mass, and also her fat distribution. And it's important to us because what we see is that 60% of women will be osteoporotic by the age of 70. And in conventional medicine, the first time women are typically given a DEXA scan is at the age of 65. Almost 50% of women will have an osteoporotic fracture in their lifetimes. So this age, where we are now in our 40s, in our 50s, being able to understand what our risk picture may look like then, and also being able to understand how we interface with that really sets us up to provide women a preventative strategy before we're categorically in that group that would need more support around osteoporosis. One other piece here too, in terms of estrogen deficiency, is that it isn't the case that we can't give any hormone replacement until women go through menopause. You know, sometimes patients will present to me in clinic and tell me that their conventional provider has said, yes, I am now using HRT with patients, but let's hold off as long as we can until you've gone through menopause, and then we'll give it to you. The truth is that actually phasing hormone therapy, when a woman is lower in estrogen and we provide her estrogen in the first part of her cycle, and a woman is also, of course, lower in progesterone and it's provided in the second half, actually treats a woman when she still has the receptor matrix to receive those hormones, and that architecture is in place in her body. So while treating women with hormone replacement within the 10 years post-menopause is still considered appropriate therapy for many women, to be able to provide it at a time where her body can recognize these hormones as what has typically been endogenous to them is actually a time where we both can intervene with smaller doses in training her body system that way. But also, it's a time where we can start to interface with this higher risk time where a loss of bone mass, which is directly related to estrogen deficiency. We know estrogen helps to potentiate osteoblasts, and osteoblasts are the types of cells that contribute to our osteocytes and our bone strength. So this is something that's very important. It's actually something I feel so much for our mom's generation. You know, they were set up such that HRT was withheld from them. They didn't have integrative providers for the most part, providing nutrients and adaptogens or herbs that can also stand in this stead. Additionally, they had low protein diets, they had low fat diets by virtue of being part of the Smartwell generation in the 80s. And that setup from a bone standpoint, from a cognitive standpoint, that's one point that's worth remarking on too. There's a very direct correlation between estrogen deficiency and cognitive change. We know that women are at much higher risk for Alzheimer's and dementia states. So of all Alzheimer's patients, only a quarter of those are men. And part of this, there's some tremendous work. There's actually a great book for anyone interested in this topic. There's a researcher out of Cornell named Dr. Mosconi. She's written 2 wonderful books. Her first book, The XX Brain, I highly recommend, talking much about how these hormonal interactions play with our cognitive structures. But she's recently written a book called The Menopause Brain. And she talks about her work looking with functional MRIs about the changes that occur in perimenopause and menopause as our estrogen storage changes. And it's really relevant and fascinating that in fact, as women go through menopause, the brain in that receptor matrix actually grows before it prunes. And what's that about? That's about the brain needing these estrogen messages in order to stabilize itself. One of the things I notice, many women in clinic, will come in and they will report either brain fog or a sense of overwhelm. Women are incredible at overfunctioning. We know this. I mean, if I took a list of all of your to-do lists today, I know it'd be brimming at the seams, right? And we expect this of ourselves, this level of overfunctioning. And one of the things that's true is that at this menopause transition, given the way that estrogen signals to our brain, one thing that estrogen allows our brain to do is multitask. So I can both be planning a birthday party and a shopping list, considering what's for dinner, and about calling my mom on some difficult topic, while I'm also caring for my kid who skinned his knee, and so can all of you, right? But when we hit this transition, we feel overwhelmed with the multitude of those tasks. First off, it is overwhelming that way, and I think we should give ourselves quite a bit more spaciousness, but also part of our capacity to do that, and frankly why many of our husbands and partners are not as effective that way, is that the way that estrogen signals our brain is in part allowing us that multitasking. When women come to me at 52, 55 and tell me, Rachel, I can only do one task at a time now, or I'm doing all my tasks as I've always done, but I feel more like a circus clown than I ever have that I can possibly grasp. That is the change in estrogen. And that's in part what Dr. Mosconi has shown, that the way our brains change at menopause is related in part to this lack of estrogenic signal. So it's very important to me that we attend to and look from a lab standpoint as to how each woman is using her estrogen, where her estrogen stores are on a total level, and also how her body uniquely uses estrogen. So as we care for her during this time, we can really solidify for her supports that are targeted to her. One thing that's also important too is that sexual health can also decline during this stage. Estrogen is a source of lubrication to us. It's a lubricant to all of our joints. It's one of the reasons many more women will have, frozen shoulder during this stage. In Chinese medicine, actually, my teachers used to talk about 50-year shoulder. And really, what they were talking about was frozen shoulder. And the fact that in America, the average age of menopause is 51. At that stage, the lubrication to that tissue will create stasis and tension and cartilage loss. And women that receive HRT have 50% less risk of frozen shoulder. Women who are diagnosed with frozen shoulder, of course, will have another reason for their sleep not being as good. And also, it can take up to 2 years for frozen shoulder to fully resolve. So this is something that I think is an important illustration. But I bring it up in the context of this sexual health conversation because lubrication in all of our tissues is diminished. One thing I feel really strongly about is that there are sources of either vaginal estriol, which is a form of estrogen that we make in our vaginal tissue, or vaginal DHEA, which is also a tool that can be used, should actually be offered to all women from the age of 45 forward. There's actually a fairly large public health crisis in our country in elderly women of UTIs that transform into sepsis. And many women, thousands of American women, die of this disorder every year. And in fact, vaginal estrogen can absolutely mitigate that loss of vaginal diversity and also the tissue not becoming more atrophied. So the fact that we're not providing that on a regular basis to all women and staving off these risk factors, I think is a real loss in not approaching it from a preventative medicine standpoint. These things are very easy to use. We prescribe them in clinic regularly, and we can always personalize something for a woman that is specific to her situation. As I mentioned before, bone health would be very relevant at this time. Estrogen is not the only tool that can support the bone matrix. Resistance training is very useful there. I often encourage patients to wear a weighted vest on their walks and in their workouts to help provide a little bit more resistance on their bones and frame. Collagen is actually effective that way. Creatine is effective that way. And we test in clinic a number of factors when we look at women's blood from a comprehensive standpoint. And if a woman is low in DHEA, which is an adrenal hormone, we actually see that that can be very useful in terms of maintaining her bone mass. So it's important for us to look at. One thing I always want to point out and take as a little aside in these conversations is the fact that women are so responsible. I want to be really careful in talking about these topics to not suggest that this is yet another thing, perimenopause and menopause, that women have to do perfectly. Women are incredible and we have a village together. But I also want women to understand that this can be a messier time and there are a lot of tools that can be available to them. But I also want us to acknowledge and grant ourselves a lot of grace, that oftentimes we need to be giving ourselves more space in these transitions. That there's a process in which toning our nervous system to receive intervals of rest and shavasana and that kind of parasympathetic approach is really an important thing. And the irony about this stage of life is that, in fact, many of us are somewhat out of practice in allowing for this relaxation state. Our nervous system, with less GABA on board, isn't doing us much favors this way either. And so I really encourage, and with Alyssa, who works with me in my clinic, she's our nurse practitioner, we really try to build a toolbox for women that addresses also this nervous system piece, whether it's guided meditation or breath work or foot soaks, or thinking about their schedule and pruning it a bit in terms of that space in their transitions. I think this is a really important time to take account of ourselves a little bit more, put ourselves back on the shelf, despite having so many dependents outside of us, who are frankly pretty accustomed to our overfunctioning too, right? So in clinic, I'll highlight a little bit about how we look at these pieces. I've already mentioned the fact that we run some comprehensive labs in clinic that are a little bit different than what conventional providers are running. And we will look at hormones slightly differently that way. We run some hormone testing. We have two kinds of hormone tests we run. We run something called the Dutch test, when a woman has still a regular cycle. It's run on day 21 of her cycle. It gives us a very broad picture about each of her hormone families, from estrogens to progesterones, androgens, which includes testosterone, and then the adrenal hormones like cortisol. But we also have hormone panels that we run when a woman's cycle is either irregular or she's on birth control. Those things give us an indication about how her sex steroids are operating and how they're metabolized. It helps us think a little bit about optimizing those systems for her so that we can attend to the HRT question in a very personalized way. We also do some genetic testing in clinic. This is Alyssa, one of her expertise areas. And the goal here is to understand across 10 categories where a woman's genetic vulnerabilities may be. Is this a woman with more propensity to dementia based on her genetics or cardiovascular imbalance? glucose dysregulation, inflammation of sorts, osteoporosis. We like to vet these particular sensitivities because we know in our study of epigenetics, which is the capacity to turn off and on the genetic influences, that we can approach these areas from a nutritional standpoint and from a lifestyle standpoint once we know that a woman's particular sensitivities have been vetted. We also run GI testing in clinic, and it's relevant, of course, to women that present with IBS or digestive disorders who haven't had that worked up enough to really get supportive care, and we look at it very thoroughly. But it's also relevant in the hormone picture because the GI system is actually the third stage of hormone metabolism, and it's where estrogen specifically is gone when it's prepared for excretion. Some women will not have proper excretion of estrogen, and so estrogen actually will go back through their system over and over. And this can be one of these setups that can be related both to reproductive related cancers and also her system having an overall higher toxic burden by virtue of simply a hormone the body was not effective at ridding itself of. So we look at that too. We know that assimilation is also important. So this is one way that our hormonal body is informed by diet and also our GI, because in fact, hormones are made from sterols, which means that hormones are actually made from cholesterol. So we should take this all in because for my generation, cholesterol was highly vilified, right? And this concept that we actually need cholesterol as one of the building blocks for our hormonal milieu is something that I think is new and should be repeated over and over. Obviously, it's important to us what kind of cholesterol a woman is receiving, and we look at those labs that help to tailor our suggestions for patients from a nutritional standpoint. But I also think it's important to note that in this age group, from the age of 40 to 60, is a time frame where more women will have gallbladder distress, which is related to fat absorption, than any other time in their lives. So optimizing her cholesterol intake and assuring ourselves from a clinical standpoint that she can receive the fats she's taking in are both really important to us clinically. And again, an area that we need to personalize. There are some things that really support the gallbladder, and I'll mention those just for your awareness. Things like beets, bitter greens, specifically we really like beet greens as well, dandelion greens. Olive oil is excellent here. Lemon juice is excellent here too, and bitters overall. So, you can make yourself a mocktail with some bitters, and it's excellent for the gallbladder health and fat absorption. Sleep is another area that's often a chief complaint for our patients during this stage. There are many factors that can inform a woman's sleep during this stage. So I want to run through them a bit so you understand how multifactorial it is and also how important it is that we focus on our sleep and give it a bit of our attention. One thing we already talked about is the way that progesterone deficiency, with this lack of GABA production, can cause us to be more activated. So that can be a source of deficiency in terms of not being able to get to sleep easily. Actually, women will tell me, they'll describe it a little bit as, I run out of sleep. I go to sleep okay, gosh, am I exhausted. But I wake up at 4 a.m. and I'm done. My sleep is over. So we find when we give hormone replacement or some of our herbs that potentiate estrogen, that when a woman's wearing a sleep tracker like an Oura Ring, I can often see that her deep sleep metrics will improve. So that's an important feature too. But there are other things that can also affect our sleep during this time. Low sodium diets, or women that are exercising heavily and losing a lot of salt as sweat, actually can be something that instigates cortisol to rise overnight. So some women who run lower blood pressure, which is much more common for women, will actually need to use a high quality salt as a tonic for their system to make sure that they don't have too low sodium, which can be a source of wakefulness for them overnight. This also can contribute to more frequent urination overnight, the low sodium state. We also see that histamine is actually a feature. So histamine is really interesting. We think of it, we associate it with allergies. This is true. Higher histamine, this is a point in which we will reflect with more allergy symptoms, but histamine is actually an adrenal hormone. It's one of our stress hormones. And so when the system has estrogen and not as much progesterone progesterone actually serves an inhibitory influence on histamine. So what that means is that in perimenopause, many women will become more allergic. And histamine, like any adrenal hormone, is very activating to us. And so some women will tell me, I feel itchy at night, or I'm having more of my allergy symptoms at night. And it's activating to them and it impacts their sleep. And in fact, this is that histamine piece that's related to this change in their immune system, which has in part a hormonal lever. Cortisol also can be undersuppressed. So we know that fight or flight aspect, as we talked about before, engaging in some interval training for our nervous system to learn to relax is also something we want to do during this time. But there are conditions physiologically, even if we were in Hawaii on vacation, that could mean that cortisol would be activated. States like low blood sugar. When a woman becomes hypoglycemic overnight, she will have a cortisol response. That's the body's incredible mechanism for if we're being chased by a tiger, we're going to be ready to run. So despite not having any glucose on board, our body is actually going to make glucose for us. But in that scenario, we will also be awoken by that cortisol surge. We also talk about the wine wake up in clinic, where women that are drinking wine the night before will often find they wake between 1 and 3 a.m. because what happens there is the body sort of runs through its detoxification, but at the end of that detox, there's again that cortisol surge. So we want to think a little bit about how we mitigate those influences and improve our sleep overall. We know that sleep, and we probably have all felt this if we've had nights we don't sleep well, is really related to cognition. And chronic sleep loss is a risk factor also for dementia. So we're in this chapter in which we have these various areas that inform our brain. And so thinking about how I can optimize sleep for each of my patients is a really important area to me because I want to optimize for brain. One thing too that we often will give in clinic is we will use for a patient who has trouble getting to sleep, that difficulty of lying down. I mean, we all know, especially now that our kids are getting older, you know, there used to be a phase where after 7:30 I in fact had time to myself. But with a tween, that's over. I'm now finally going to sleep before my almost 12-year-old, and I have to do that. But I think that partially that wind down at the end of the night, we often feel like our work is never done. And melatonin is something that we will use because it improves sleep latency. So what that means is that it improves our capacity to fall asleep. Melatonin does not keep us asleep. It's helpful for women that have trouble getting to sleep. We use a low dose melatonin in clinic, it's 0.3 milligrams, and there's no data to suggest that exogenous melatonin would undermine our own endogenous production of melatonin. But we do find that melatonin actually is on the pathway of serotonin production. So one thing I find for some women, we test melatonin in the testing that we do, so I can see whether it would be a relevant strategy for our patients. But in the case that it is, it also can be an improver to a woman's mood as well, because it supports those serotonin pathways. PMS insomnia is, to me, a progesterone tell. So it's something I see in clinic, and my first thought is we need to get a sense of where this woman's progesterone stands. We use some tools like magnesium, which can be helpful when there's a feature of the muscles feeling very tight or tense, jaw tension, migraine headaches. Magnesium, most of us, about 70% of Americans, are deficient in magnesium. We're choosy about the type of magnesium that we use, and we try to personalize that to our patient, but it is something that is often useful. And also, in training our sleep cycles is important. Most of us have probably heard this by now. Our sleep starts in the morning. So this is this idea that getting some sunlight in our eyes in the morning hours start to set our circadian clock during that time. In the same way, all of our organs actually run on a circadian clock. And so it's worth noting that it's useful for us to go to sleep and wake up at relatively same times every day. So often we may have one day a week where there's a deviation there, but aiming to really set that rhythm and ritual in our physiology will make it easier for our body to receive that kind of rest as well too. So in terms of the glucose piece, when I spoke about hypoglycemia, one tool we also often use in clinic during this stage, because it also relates to metabolism for women, which I'll speak to in a moment, is we'll often put a continuous glucose monitor on patients. Continuous glucose monitors, I think, are an incredible technology. You put them on, you don't really have to think about them again. They stay on for 10 days at a time, and they monitor, without your having to do any scanning, your blood sugar throughout the day and night. This is helpful to me because I can see whether a woman might be falling hypoglycemic overnight. I can see whether stress is a factor in a woman's spiking of sugars. I've had a number of patients who will show me their blood glucose trends, and the only time their sugar spiked throughout the day was when they had a board meeting or a difficult call. So it's useful for us to understand for each woman what might be the driver of her underlying blood glucose imbalance, and correcting that both improves sleep and is very informative to the way our metabolism changes at this time. So metabolism is really an important topic. Many patients will come to me, and again, their chief complaint might be feeling like they're having more loss of lean mass, and they're suddenly have a muffin top where they feel like they have abdominal fat they've never had before, and they're doing everything the same as they always have, and they're wanting to understand. So I'll explain to you a little bit about what are the levers on metabolism at this phase. So there are really two main levers, and there are more, but these are the central ones that kind of inform everything else. The first is that as our system wanes in these reproductive hormones, we talked about how there's less suppression of our activation symptoms, right? So the more cortisol and stress hormones that our body are making, the more our body is prepared to run from the tiger. Running from the tiger requires fuel. So our body has an incredible way of establishing its own source of glucose, and that's in the liver. So one of the things that happens when we spike stress hormones is our liver actually engages in something called gluconeogenesis. Our blood sugar starts to rise at this stage of our life, and as a result of rising blood sugar, the body makes more insulin, because we remember that insulin is the key that takes the glucose we have in our bloodstream and brings it into our cells. Well, here's the trick about insulin. Insulin is a fat storage hormone. So the more insulin a woman makes, the more her body will dispose to put her fat in a visceral area. This is ironic too, because the more visceral fat or abdominal fat that we have, the more inflamed we become, because all of our main organs are in this area. So visceral fat is actually the fat that is damaging to our health. We may find subcutaneous fat, which is more the female distribution of fat that comes in our bum and our hips, to be a nuisance perhaps, although I think Kim Kardashian's rocking it. But this visceral fat is really what's dangerous to us. And so on the DEXA scans that we run, we actually see for a patient where her fat distribution lands. And in clinic, we run metrics like fasting insulin and hemoglobin A1C to understand where a woman's insulin load lays. Because if we can inform this area, and really this is informed very much by blood sugar control, then we can reduce her insulin overall. This both reduces her fat load from a visceral standpoint, but frankly, it also means that we're reducing her inflammatory load. And that inflammation is so much at the basis of so many of the diseases of aging. So it's important to me that we understand a woman's vulnerabilities here at this stage and set her up to have the least inflamed tissue she can have. So the other piece here in terms of, well, how do I stabilize my blood sugar diet during this stage? Women, we know, need much more protein as we age. Our body's capacity to absorb protein is reduced as we get older, and we lose muscle mass as we lose estrogen. So one of the things that we encourage our patients are to aim for at least 90 grams of protein a day. And I ask patients to try to have 30 grams 3 times a day. We call that a protein bolus, right? So that would introduce those amino acids in these 3 different cases so the body has time to absorb and use those amino acids. One of the things that's very useful too is thinking about at each of those meal times, having some protein, some fiber, some veggie, and some anti-inflammatory fat like olive oil, seeds, nuts, salmon, avocado. All of these things help to stabilize the blood sugar because these macromolecules burn much longer duration than a carbohydrate does. That's not to say I'm not a fan of fruit or carbohydrates at all. Certainly, we for the most part don't prescribe a ketogenic diet at clinic. But we do find that protein contributes to satiety. And one of the things that changes with these hormone changes is women will often describe feeling like their appetite isn't satisfied. And part of that can be related to having less of these hormones. So when we contribute to satiety with protein, we help to establish more of that baseline for women too. Is women telling me they're doing intermittent fasting. I have to tell you, globally, that I'm not a fan. Part of this is because sleep is a catabolic event, which means that overnight, we're repairing and recovering our system, but we're also breaking down muscle tissue. When we wake up in the morning, our cells are primed to receive protein to engage in muscle protein synthesis. So I want to make sure we're giving our body during that time that muscle building block of protein. So many women are waking up, caffeinating, and then working out, and all of those things put the body back into a fight or flight mechanism. A lot of patients will tell me I'm not hungry in the morning, or my stomach isn't prepared for a big slice of frittata. Totally fine. We also work with our patients to develop strategies like what would a protein smoothie look like for this patient? And we'll build something in so it's something that's more approachable for her. But I do want her nervous system to have the cue that she's stabilized and that high intensity workout with nothing under her is not just another event of being chased by the tiger. Because from a metabolic standpoint, that's actually very counterproductive for patients. So in the same way, we talked a little bit about how our capacity to build muscle and lean tissue during this stage can be more depleted. But there are many levers that we have to improve the system. Protein is an excellent lever, as we described. Resistance training is an excellent lever as well. So moving away from more of our high intensity cardio work into more of our muscle building. Muscle is an incredible tissue metabolically. A pound of muscle will burn 25x what a pound of fat does. So the more of our mass that we can convert into muscle mass from fat mass, even if it's just a few pounds, our metabolic rate will be established. And also, our muscle mass helps to build our bone mass. So it's something that's really useful across the board here. I really like to emphasize with women at this stage that this is a chapter where we can focus on being anti-fragile, right? I want my patients to go into this next 50 years of their life solid and feeling like the risks that have become our mother's generation, risks of falls, risks of sarcopenia, risks of brain loss, we really can interface with these things at this time in a very preventative way. And I want women to feel like they're bolstered and shored up. There are a couple other things as well in terms of muscle mass. There's some interesting data that suggests that high-dose omega-3s actually helps to contribute to the retention of lean mass. They've done a number of studies. Most of these were done in Canada. There's an incredible protein researcher there. But he's done some work showing that 2,000 milligrams of omega-3s daily, actually for patients that were forced on bed rest for 3 weeks, which would be a scenario in which patients in the perimenopause, menopause range would often lose in that time almost 25% of their muscle mass. That by using omega-3s, they actually can maintain the amount of muscle. There are many other benefits to omega-3s on mood. Omega-3s go head-to-head with Prozac in terms of their efficacy in terms of the treatment of depression, and they're anti-inflammatory. But this piece on muscle mass, I think, is excellent. There's another nutrient that we use too. It's a postbiotic. It's called MitoPure, and this too has been studied very thoughtfully in terms of the retention of muscle mass. So in clinic, we try to build a toolbox specific to that patient's needs, but I think all of us should be thinking about this anti-fragile feature and how we retain our muscle mass during this phase. We also know that perimenopause and menopause, like all hormonal transitions, is a time where women are more susceptible to changes in thyroid changes. So for women, thyroid metabolism is really one of the key features that helps to drive our metabolism. We test this in clinic, and we look at the full cascade of thyroid hormones, From the conventional side, they'll look at TSH, which is thyroid stimulating hormone. It's the target they look at for pharmaceutical treatment. But we look at all the ways that thyroid is made and converted in the system. That's important to us because interfacing with this will both improve a woman's energy production and her metabolism, but also understanding where this hormonal transition could be a feature for her in driving that thyroid change is important to us. One thing that often will occur as women move through this chapter is that as estrogen wanes, many women will have an elevation in their cholesterol and their lipids. This is actually normal because, as we talked about before, what are hormones made of? They're made of cholesterol. So our body is thrifty, and this goal of giving ourselves, retaining more of those core ingredients to make hormones, our body will hold on to more of that cholesterol. But many of my patients will present late 40s, mid 50s, telling me that for the first time ever, their lipids look out of range. We look at this very thoroughly. As we talked about, we'll look at this genetically to understand some of her cardiovascular risk. We'll refer patients out to have a very non-invasive test called a calcium artery scan to actually look at the amount of plaque or non-plaque she may have in her tissue. These are useful to us because it's not our belief that all women should simply be put on a statin. There are many reasons why our body is trying to hold on to more of this cholesterol, but vascular health is a really important topic because before menopause, women's risk of a vascular event is half that of men, heart attack and strokes. After menopause, our risk is equal. Cardiovascular disease is the leading cause of death for women. So this change is a time where we want to think a lot about bolstering a woman's vascular health and understanding if that's an area of sensitivity for her. We already talked a little bit about how protein builds satiety and this idea of 3 times a day having protein, fat, fiber, and grains. One thing I wanted to mention, as I said before, is that protein's important, and animal protein, inclusive of fish, does tend to be higher quality protein from the standpoint of our body because it's richer in certain amino acids, particularly one called leucine, which allows us to build muscle more easily. But I do want to say that's not to say that plant proteins do not have value. They do. Actually, in Japan, where women have a much higher diet in soy products, which is probably the highest ranking source of plant-based protein from the standpoint of our capacity to assimilate protein from it, those women actually have a 40% reduction in perimenopause and menopausal symptoms. So not all soy is created equal. Please don't go to Starbucks and get that really processed soy latte. So soy milk is made from soy protein isolate, and I'm not a fan of it. It's highly processed food. But high quality, non-GMO tempeh, tofu, yuba, these foods are excellent, and they can be a baseline support both from a standpoint of soy being phytoestrogenic. They're also easier to digest and absorb for some women than huge amounts of meat, but they also may have the secondary benefit of supporting the hormone libido. Talked briefly about bone, but I do just want to touch on a couple of things. And part of this is a bit of a public service announcement. I don't have daughters, but some of you do, and I've been trying even at my kids' school to let them have me come in to talk about this topic because I think it's really important and I want young women to hear about this. So one thing that's true that we now know is that oral contraceptive pills are made of a synthetic progestin. Many women in our generation were on oral contraceptive pills for some duration. Most of my patients actually probably have been on them for 1 or 2 decades throughout their life. One thing that we didn't hear about though from providers when women were put on oral contraceptive pills is that it's a low estrogen state that they create. So this is part of how providers, when young women come in, are controlling for skin symptoms or controlling for irregular cycles, because the truth is it's natural when young women begin to ovulate that they actually will not be ovulating for the first few years that they get their period. So as you recall, reverse puberty, this means that a woman is not making much progesterone in the first few years. So she, there too, has estrogen unopposed by the dance partner. The trick is though, if we put her on birth control in this key stage in which she's building bone mass, most young women's bone mass will be complete in their building at around age 18. So if women spend years during that time on birth control pills, we're actually really diminishing this core stage in which they can build bone mass. And all of our bone mass too is informed by the duration of time that we may have spent on oral contraceptive pills as well. So I don't fault conventional providers. I think this wasn't something that was thought about, and I feel for them too, because I get an hour with my patients and they have 7 minutes. So I don't need to suggest that they're in the wrong, but I do think that we all should know that this is part of the downside of oral contraceptive use, is that it's not optimal for our bone health. I also want to emphasize that oral contraceptives are not HRT. So I have patients that will present to me every month that will come in and say, oh, my doctor finally put me on HRT. Okay, what are you taking? And in fact, they've been put on birth control pills. Birth control pills are not appropriate to this stage of our lives, in part because this is our final gas at retaining our bone mass. And also, it can mask the underlying symptoms of our estrogen and progesterone deficiency, which I would rather attend to head on. The progestin that's in birth control pills does not give us the neurotrophic effects of bioidentical progesterone. And as a result, we don't get the reduction in anxiety or the improved sleep that we would get if a woman was actually taking bioidentical progesterone. So it's important to me that we be aware of those differences. So HRT, yes or no? I think that this is something that's been obviously a really big sea change in our lifetime and in recent years, and I want women to feel really informed about it. Most of you have probably heard of the Women's Health Initiative. This was the whole study, the biggest study ever that was done on women's hormone replacement. It will never be duplicated to the scale it was done. It's such a shame. But it was done on the wrong women with the wrong drugs at the wrong stage of their lives. So what this means is that the mean age of women in the Women's Health Initiative was 63. Those women were more than a decade out from going through menopause when we know that receptor matrix is primed to receive hormones. And also, they were given a synthetic form of progestin, not bioidentical progesterone, which doesn't have these neurological benefits of progesterone, and they were given oral estrogen. Oral estrogen is not a form of estrogen we would ever give today because it comes with a clotting risk. And in fact, it can really be challenging to women with a cardiovascular risk. And in fact, that's part of why these were the wrong women to study these medications on. Half were smokers. So we already had a group of women that was at much higher cardiovascular risk. But one thing that has been interesting that has come out of this data, because the news headlines at that time, the study was not completed, it was halted because there was an observation of a small group of women in the study that had a slightly elevated risk of breast cancer. What was printed in the newspapers at that time was that HRT causes breast cancer. All women our mother's age were taken off their HRT at this time. In fact, the estrogen-only arm of the Women's Health Initiative we now have a cohort study on that group because the study was completed in 2001. We have a 30-year study on those women, 30% reduced risk of breast cancer, even in the oral estrogen, which we would never give today. This makes sense, right? Because many more women have breast cancer postmenopausally, in a low hormone state, not in the high hormone state premenopausally. However, it was true that in the arm of the study that used an oral estrogen and the synthetic progestin, that group had a slightly higher risk of breast cancer. So one of the things, the takeaway here, is that I want you to know that the type of hormone replacement that's used today is not the same group of men. We don't encourage women in their mid-60s to come on HRT. We are studying closely now the question as to whether women have begun HRT in their 40s or 50s. I think actually the likelihood that we may be able to retain HRT for some of those patients very safely is in fact going to be shown to be true. There are also trials in place now for women with pathologies like breast cancers or other hormone-related cancers, in which there are studies being done on what we call designer estrogens, which essentially are estrogens that have affinity for bone and brain, but no affinity for our ovaries or uterus or breast. And we also have a number of herbs that we've been using for years and have clinical trials behind them, that even if my patient is actively undergoing care for an active breast cancer, we can use without raising her estrogen levels, but we can support some of the symptoms that come up with tools like tamoxifen, which often will put women immediately into menopause. So one of the things here in terms of considering HRT for each patient is to understand that on the conventional side, again, because a lot of docs do not have the duration of time that we have, there's protocol care. Oh, you would like HRT, here it is. And I see in clinic every week women that present that are not tolerating the HRT that they've received for a variety of reasons. And for us, what we like to do before we use HRT is do some evaluation of our patients. Understand where is that person's estrogen, her progesterone, where are her androgens, because sometimes we even use testosterone therapy. Women actually, little known fact, have more testosterone in their systems than they have estrogen, and we need it. It contributes to bone, muscle mass, and it's actually very helpful in terms of libido and even confidence. So we test all of those things, and we also test how the body would use hormones, because there's some pathways by which the body uses estrogen that's very protective to us, vascular system, brain, bones, and there's some pathways that the body would use estrogen that's more damaging from an inflammatory standpoint, or more damaging from an oxidative stress standpoint. And we want to make sure we vetted that could be a risk for our patient, and then use tools like nutraceuticals or diet that are targeted to move more of her processing over into these pathways that are protective and anti-inflammatory to how she uses them. So I don't think the answer on whether HRT is the strategy is a yes/no answer. As I told you before, been in practice for so long that for the first 12 to almost 15 years of my career, we didn't use any HRT. We used herbal medicine, it was very effective, and I watched these same data points. But I am interested in the use of HRT for many of my patients, because there are cases in which it can minimize the number of supplements that they might have to take or nutrients, and it's more efficient. Or if a woman has a risk of dementia, or a woman has a risk of osteoporosis, or we see vascular changes, I really want to think about for that patient what's relevant to them and appropriate. We already talked DHEA. DHEA can be very useful for a woman's bone mass and also for these energetic reserves, so it's something that we test as well. I know that I'm very passionate about these topics, and to be candid with you, I could probably talk for another hour, but I'm sure that it's a lot of information, and I want to make sure to leave some room to answer your questions and be thorough in that regard. I do just want to touch on one last topic before we get there, and that's the microbiome. I just want to speak a little bit about the way that these hormone changes affect changes in our microbiome. We know that as estrogen wanes, our diversity of our microbiome also wanes. And that's relevant because there's a number of studies, even in centenarians, they show that longevity is associated with microbiome diversity. Full stop. And one of the things we can do to contribute to our own microbiome diversity is to aim to have 30 plant foods a week, a variety of them. We also, for a long time in nutritional medicine, it was assumed that all patients should take a probiotic. In fact, the data is not there. We do use probiotic in clinic when we see that a woman has a dysbiosis on a test, and we know exactly and precisely how to intervene. But there are a number of studies, there's a tremendous group at Stanford that's doing this work, that has shown that ferments and fiber are actually better in terms of your body using those building blocks to make its own probiotics. We do give prebiotics to some patients, helping to, again, sort of fertilize the soil of the microbiome. But as you recall, the microbiome is relevant to our hormones and how we process them, even if we're postmenopausally and using HRT, because the GI tract is the third stage of hormone metabolism and where estrogen is excreted from. So if we don't retain a stable microbiome in our GI tract, then our body's not able to use and then release the estrogen it no longer needs. So this is a target area that we really want to optimize. We're going to see some incredible research, even in the next few years, on the way that the microbiome informs our nervous system. Many of us have heard about the vagus nerve, and the vagus nerve, vagabond, vagus, it's a wandering nerve, it's the longest nerve in our system. It communicates between the brain and the GI, and from the GI to the brain, and it's very relevant in the production of neurotransmitters. So having a more diverse and balanced microbiome also truly affects our mental health. And there's some really interesting research here. Ultimately, even the production of things like psychobiotics, which essentially just means using forms of probiotics that are known to improve our body's production of dopamine or serotonin and are relevant to brain health. So stay tuned for that. I actually think it's going to be a really useful area of research. I want to move towards your questions. And I do just want to say, and I think we touched on this in a roundabout way, but I want to just say it directly, that I do think something I see for my patients during this time, and I really encourage us all to think about, is turning the interoceptive gaze towards ourselves during this time. What I mean by that is that I think as mothers and women, our gaze is so often outward. The women around me are so productive, they're phenomenal. And I think that that practice of turning the gaze more inward on ourselves, even cultivating more of a listening for when we may need a rest or when we may need a drink, and I mean water, is a really important stage of coming back to ourselves. You know, some women will come into me to clinic during this stage and they'll feel like, oh, I'm a more limited version of myself. But actually, one of the things I'll notice is that a lot of this stage is a call home to ourselves. And many of us have been extended in all these directions outwards. And I find that as women do cultivate more of that interoceptive gaze, they find a new communion with themselves and a new peace. And I have to say that most of my patients postmenopausally, they're more unapologetically themselves. And I really relish being around women that have taken up a little bit more space for themselves that way. So I invite you to come towards yourself that way and allow yourself to take a little bit more space up too. So I know there's a lot here and surely some I didn't touch on. So I want to make sure to answer your questions. Thanks for being so attentive. I know I can go on and on. But here's what I recommend. I mean, I'm biased, right? I recommend whole person medicine. So I want to look at the root cause of where the imbalance is and attend to that. So if a young woman's having irregular or painful cycles, which is really common when they're not yet ovulating, then I want to help her body process that estrogen. It doesn't have its dance partner. So we have nutrients and nutrition that can support with that. And I also want to think a little bit about that passive microbiome for her too, stabilize those things. If it's skin and she's noticing for the first time more cystic acne or irregularity there, again, can be a feature of unopposed estrogen. Then I want to think a little bit about the way that the gut mucosa is reflected in the skin. So in that case, I'd probably run a GI test and understand where those imbalances were and attend there, while also using some cofactors for smoother skin like evening primrose oil and zinc. So that's how we would approach it, because the idea of using hormones at a stage when young women are establishing their reproductive rhythm, I think part of this is related to my bias of treating so much fertility for so many years and having so many women come to me in their late 30s ready to be moms and for the first time coming off birth control, and their body was then doing the work that I want our young women to be able to do physiologically in their teens. So it's not to suggest that it's easy to have painful periods, and 1 in 10 women does have endometriosis, which is an inflammatory disorder of estrogen dominance. But again, that's something I want to vet for her right away, because it might be a feature that would inform her future fertility, but it's also something that she deserves to have tools to not be in pain that aren't just suppressive, but attend to the root cause. So it's my biased perspective, but I would really encourage young women to not use birth control. Yeah. Other questions?
You mentioned the shift in GABA, and I'm just wondering if there are foods that support GABA production.
Yeah, so GABA's a little bit trickier because I would say that we approach GABA more from a neurotransmitter standpoint. So we use more nutrients and progesterone itself.
Okay.
So it depends a little bit what we see on testing. If a patient comes in to me and I can see right away that either her chief complaints or how she presents suggests that the nervous system is overactivated, she tells me she feels anxious, it's hard to relax, it's hard to sleep across her whole cycle, so that wouldn't be only progesterone. And in that scenario, we have a number of nutrients that can both truncate the production of stress hormones, so she doesn't have to feel flooded by that physiologically so much of the time. And we also will add things that lead to and support that GABA relaxation response. So that would be like magnesium. There are other neurivines that work there. Rosemary works there too. I'll have that patient soak her feet in warm water with Epsom salt because, as you know, Epsom is magnesium. Again, I'll think a little bit and talk with her about the programmatics of her life so she can start to do some of that interval training to her nervous system. For instance, after exercise for a really activated patient, I'll always ask them, and I don't mean at yoga class, but after whatever exercise they're doing, to take a Shavasana interval, because I want her body to store that kind of more active work with a pause. So those are some of the things. And then in many of our patients, we will give progesterone if we see that that's indicated, but we test for it first. So, not obligated to have your questions now. Feel free to shoot me an email or let me know if there's anything that comes up after the fact. I hope it was informative. I hope it wasn't overwhelming. I hope if there were topics you wanted treated, they were attended to. Be generous with yourself. Thanks for being here.
Thanks.